Okay, Chair, we have about 1 minute until 9 a.m. and then you may call the meeting to order.
Did you get online on YouTube live?
So the YouTube is not connecting at the moment, but I did confer with our DAG and she noted that if there's technical difficulties, what I'm doing right now is I'm recording this meeting on my computer and I will upload it to YouTube after the meeting.
Okay, that makes sense. So, all right, it's 9 a.m. So I'll call the meeting to order. So let's go for the roll call, Melinda.
Absolutely. Thank you, Chair. All right, Commissioner McAllister.
Good morning, present.
Good morning. Thank you. Chair Khan.
Present.
Thank you. Commissioner Roe-Dugan.
Present.
Thank you. Commissioner Van Houweling.
Good morning, everyone.
Good morning. Thank you. Commissioner Tyler Garner. Oh, she is here. So she was moving to location. So I know that she will reconnect shortly. Commissioner Winkler.
Good morning, present.
Good morning. Thank you. Vice Chair Rivlin.
Good morning, present.
Good morning. Thank you. Commissioner Ralston.
Good morning, here.
Good morning. Thank you. And the following commissioners did note that they would not be able to make the meeting today and are marked as excused. That includes Commissioner Grady, Commissioner Bond, Commissioner DeCerbo, and Commissioner Khan. And Chair, you do have quorum.
Thank you, appreciate that. And just for the record, Commissioner Sarah Collier had indicated she may have to get off the meeting earlier, which is perfectly all right. But appreciate you being here, Sarah. So moving along, since we do have quorum, the next item on the agenda is the approval of minutes. Do I have a motion to approve the minutes if everybody has reviewed them?
Yes, Chair Khan, this is Commissioner Van Houweling. I'd like to make a motion to approve our past meeting minutes.
Is there a second?
This is Commissioner Winkler, a second.
Thank you. And anybody opposed? Hearing none, the minutes stand approved. We have the next item is public comment. Melinda, do we have anybody in public comment, north, south, or online?
Sure, I will ask if you have public comment and you are on the Zoom platform, please use the raise hand feature. If you are calling in, please press *9 to raise your hand. And public comment, so far I do see Mr. Kelly with his hand raised. I will unmute and ask Mr. Kelly to please address the commission.
Just a reminder, we have 3 minutes for each public comment, so kindly respect the time limitations. Go ahead.
Good morning. My name is Patrick Kelly, and I'm the CEO of the Nevada Hospital Association. Today, I'll address inflationary pressures on healthcare providers and how it affects cost and access. In a letter submitted to the PPC, I outlined the tremendous cost growth pressures on hospitals and other healthcare providers. The cost of labor, supplies, and drugs have increased rapidly. Each has risen more than twice the level of the governor's cost growth benchmark of 3.19%. It's unreasonable to think that healthcare providers can contain costs under 3.19% when inflation is surging. It's important to remember that the cost growth benchmark was established when inflation was supposed to be transitory. Today, everyone agrees that the inflation rate in America is not transitory. In his executive order establishing the benchmark, Governor Sisolak recognized that the economy might change. He wrote, "Should the PPC find that there have been significant changes to the economy after the effective date of this order, it may recommend to the governor changes to the cost growth benchmarks. The PPC should recommend to the governor that the targets be modified to reflect inflationary pressures. If the PPC provides to codify the provisions of the governor's executive order, codification should include language that accounts for inflation." The governor's executive order also stated that relevant partners should be engaged to develop strategies to help meet the targets that are data-based and practical. That engagement should be made a condition of PPC action. We offer one strategy that is data-based and practical. Increase the number of nurses in Nevada. Nevada's nursing shortage is severe. Earlier in the year, hospitals paid more than $250 an hour for certain nurse specialties. Some nurses were making more than doctors. While prices for traveling nurses have decreased somewhat, hourly rates are still exorbitant. The salaries of staff nurses have increased too. The NHA conducted a survey of its member hospitals. We asked hospitals to provide the number of staff openings they had on July 1st, 2020. Here are the results. RNs, 2,393. That's almost 2,400 RNs. LPNs, 188. CNAs, 616. This is just for hospitals. We know other healthcare providers have significant openings too. For months, hospitals have averaged approximately 407 patients daily who are medically cleared for discharge by their doctors, but cannot be discharged from the hospital. Post-acute providers have the beds, but they don't have the nurses to staff them. Keeping patients in hospitals unnecessarily drives up costs, but more importantly, it causes access problems. If patients cannot access the post-acute services they need, they will not recover as well. We don't need a big, expensive study to identify one of the biggest cost drivers in Nevada. It's simple. The lack of nurses in this state is a huge cost growth driver, and we encourage the PPC to address it swiftly. Thank you.
Thank you very much. Anybody else in public comment, Melinda?
Anyone else wishing to give public comment, please either use the raise hand feature or press *9 on your phone. Chair, I'm not seeing any additional public comment. However, I do want to note the commission did receive written public comment for today's meeting from the Nevada Hospital Association, which was sent to the commissioners on October 7th and is posted to the PPC website. And I did want to quickly note that the commission does have a plan to have a more in-depth discussion regarding implications of inflation for assessing Nevada's healthcare cost growth benchmark performance during next month's meeting in November.
Thank you, Melinda. So moving along with the next item on the agenda is presentation from healthcare cost growth benchmark from the state of Oregon. We have allocated 20 minutes, including question time. So can we proceed now? I believe Sarah Bartleman is going to present.
Yes, thank you, Chair. So just to quickly introduce this presentation. So our neighbors in Oregon are also a healthcare cost growth benchmark state, only they refer to their program as a target rather than a benchmark. And as part 2 of the discussion the commission began last month, we've invited Ms. Bartleman from the Oregon Health Authority to address the commission today to help understand more about how other benchmark states are incorporating accountability mechanisms, as well as to convey some lessons learned over the course of implementing the healthcare cost growth benchmark in their state. And obviously Oregon is not Nevada and every state is uniquely different. However, it is important to learn from what other states have experienced so that Nevada can continue through our critical benchmark planning phase and allow the commission to decide what from the menu of available options might work best for Nevada and how we might learn from some of the trials and tribulations and successes experienced in other states. Now we'll turn it over to Ms. Bartleman for her presentation. Sarah, please feel free to go ahead.
Great, thank you. Good morning, everyone. Hello, commissioners. Thank you so much for having me. I'm Sarah Bartleman. I work for the Oregon Health Authority, and I manage our cost growth target program. So I know last month you heard a very high-level summary of our accountability mechanisms. Today, I'm going to talk about those in a little bit more detail. I'm going to share a little bit about how we work with payers and some of the lessons learned from the data submission. But I'm going to start with just a quick summary of our target setting and implementation journey because it has been a multi-year process for us. Next slide, please. So Oregon originally began considering how we would address cost containment, healthcare costs back in 2017. We had a legislative task force that was specifically charged with looking at a hospital rate setting model, specifically Maryland's hospital rate setting model. Ultimately, that task force agreed that a cost growth target or cost growth benchmark program like Massachusetts had at the time would be the most appropriate path for Oregon. That led to our establishing legislation in 2019 that stood up our cost growth target program within the Oregon Health Authority and launched our implementation committee, which functioned very similar to your roles in Nevada. We worked with that implementation committee for the first couple of years to develop recommendations to guide the program, plan through some early implementation pieces, and come up with accountability mechanisms. We had a deliberately staged process where we followed up in the 2021 legislative session with a second bill that established the accountability mechanisms as recommended by our implementation committee. So 2 bills, deliberate time to roll that in. Next slide, please. We also have a pretty long phased in implementation. So as well as the legislative process and the work with our implementation committee that I mentioned, we also have been slowly rolling out program guidance. So we've been putting out our data submission guidance. So we've launched a technical group for our data submitters. We've been developing the accountability mechanisms. Earlier this year, we began engaging with our provider organizations that are included in the program. We are beginning state and market level public reporting, and then early next year we'll begin payer and provider level reporting. We are also just starting to get into identifying strategies to help achieve the target. We have one that I'll talk about in a minute, but we know that that is going to be a big piece of the work for our committee and our program moving forward. We do have 2 accountability mechanisms that I'll talk about more in detail, performance improvement plans and financial penalties, but I just want to note here that they take several more years to phase in. So performance improvement plans don't begin until 2024 at the earliest, and financial penalties don't begin until 2027 at the earliest. So again, based on our establishing legislation, we wanted to have a pretty long on-ramp for that. And that was based on a lot of feedback from payers, providers, stakeholders about the time that it takes to make some of these changes and implement some of these initiatives, things like the time it takes to roll changes into contracts and let that show up in the data really led to us having this long timeline for implementation. Next slide. Just to provide a little context, our cost growth target has been set for the next 10 years. It exists longer than that. It doesn't sunset in 10 years, but we've set the target value for 10 years. So for the first 5 years, it's set at 3.4%, and then it is tentatively set at 3.0% for the second 5 years. Our committee is specifically charged with coming together in 2025 and revisiting whether or not that drop to 3.0% is still appropriate. And as like you just heard, we're having very similar conversations about inflation, those inflationary and workforce pressures in Oregon, and that will certainly be feeding into our ongoing conversations. One thing that's different about Oregon's cost growth target, maybe relative to some other states, is our target value is not directly tied to an economic indicator. So I know some states have selected potential gross state product +1 or potential gross state product plus CPI. Our target is informed by. Our committee looked at a lot of economic indicators and triangulated to come up with these values, including median wage and median income. We really wanted to make sure that the consumer perspective was part of that, but our target is not directly pegged to an economic indicator. Okay, next slide. The one strategy that I mentioned that's already launched for addressing cost growth is accelerating the adoption of advanced value-based payments. And this is something that our implementation committee identified as a priority in 2021. And that really builds on some work that we've done with our Medicaid managed care programs. We already had some advanced value-based payment requirements for Medicaid managed care and contract. Our implementation committee identified this as a key strategy for achieving the target, as well as really in line with some of the other state priorities. And this resulted in our implementation committee setting a set of principles and setting some target values for advanced value-based payment. That work has now spun off into a voluntary compact and work group that is a joint partnership, public-private partnership between our agency and the Oregon Health Leadership Council. We've had, I'm going to get the numbers wrong. I want to say it's over 40 signatories, payers and providers both, to the compact, and that represents over 3/4 of all of the covered lives in Oregon in the organizations that have signed on. So there's a lot of work that is happening here related to developing strategies, developing models for value-based payment, providing technical assistance, and more, and really supporting payers and providers in meeting the targets established in the voluntary compact. Okay, I'm going to switch gears. Apologies for sort of being a little bit all over the place, but wanted to give you a flavor of what was happening in Oregon. So a little bit of background on working with payers and what our data collection process and lessons learned have looked like. Next slide, please. So for some context setting, Oregon has a really broad charge. Our establishing legislation clearly intends for our target to apply to all providers and payers, both public and private, in the state. That is a lot. And if you think about all payers and providers, do you translate that as every individual clinician is then subject to the target? So our implementation committee spent a while thinking about what that actually means and how to implement and operationalize that charge. But I just wanted, our legislative direction is the cost growth target applies to everyone. Next slide. So our implementation committee, where we landed was that our measurements, our cost growth target, should be inclusive of spending on behalf of Oregon residents who have Medicaid, Medicare, and commercial insurance. Our commercial insurance does include self-insured, and I'll talk more about that in a minute. Medicare includes both traditional Medicare and Medicare Advantage, and Medicaid includes our managed care and our fee-for-service. We are also including other supplemental sources of coverage and spending, including spending through the VA and spending through our Department of Corrections where we can. So there's some sort of piecemeal additions. Really, this all adds up, and we're collecting spending on behalf of more than 90% of Oregon residents. Next slide. So with that, understanding our parameters, we want to include all insured lives as we can, but Oregon has a really rich domestic insurance market. This is one place where Oregon is maybe different than a number of other states. For example, we have 15 Medicaid managed care plans, 21 commercial large group plans, 26 Medicare Advantage plans, 28 commercial individual small group, and almost 90 self-insured plans that we know of. There is no definitive list of how many self-insured plans there are operating in Oregon because we don't have any requirements for sort of tracking that. So that's a lot of payers to work with, and thinking about how many of them should be in under this program and what that means in terms of data submission and data collection. This was a really different charge than a state that maybe has one or two large national carriers operating. So our implementation committee gave us a little bit more guidance. Next slide, please. So we tried to create some thresholds for how to structure this conversation. So first, we thought about how to only collect data and report on cost growth for payers that meet a minimum population size. So we essentially created 3 tiers here. So payers that are required to submit data to the program, payers that meet a threshold for public reporting, and then threshold for accountability. And all of those are set differently because of the wide range of size of covered lives that we have. So again, we wanted to make the data submission piece as broad as possible so that we could be as inclusive as possible. All payers, all providers, as many covered lives as possible would be included in the program, but that we would then not report on everyone because of small numbers in particular, and then also not hold some of those smaller organizations accountable. I also want to say that in Oregon, we have a lot of payers on that list that I just rattled off. There were a surprising number of them that had fewer than 10 members enrolled. So they might be an out-of-state company that's self-insured that has some workers based in Oregon. But we were talking about some really small numbers, and we had to decide whether or not that would be appropriate for data submission. Next slide. So this just illustrates that sort of long tail of payers and TPAs in Oregon. Where we ended up drawing the line for data submission was payers and TPAs that have at least 1,000 covered Oregon lives. So the bars are the percent of total reported covered lives, and the orange number is the number of payers that represents. So at the far left of this slide, you can see we dropped 134 payers that had less than 1,000 covered lives in Oregon from our potential requirement to submit data. This still leaves us with a lot of payers that need to submit data, but it was not as many as it could have been. Next slide. So I want to show you just this as an example of our reporters and how we are handling self-insured. So for those payers that have a self-insured line of business and other lines of business, we are asking them to just provide their self-insured data as part of their commercial market. So in this slide, what I want you to look at is the Regions Blue Cross Blue Shield line across the middle that has numbers in the lives. So they have a fully insured commercial, they have self-insured, they have TRICARE, they have Medicare, no Medicaid, but they are operating in most of the markets. So we are asking them to submit, and we are considering them a mandatory reporter for their self-insured lives as part of their commercial reporting. Then we have some other examples of payers that have self-insured lives only. For those, because of ERISA and other various considerations, including that we don't know who they all are, we have sent an invitation to participate to those payers and invited them to voluntarily submit their self-insured data. We actually felt pretty confident about that because we do have quite a bit of voluntary self-insured data submission to our all payer claims database already. Maybe not surprising to you, we did not get a lot of uptake on that from that voluntary invitation to submit data. But I will say that for all of the other payers that have self-insured lives, in addition to the rest of their lines of business, we are receiving that data. Next slide. So that this just narrows in on that Regents Blue Cross Blue Shield example. So we are including all of those lives highlighted in orange as part of our commercial data, and we're including the Medicare Advantage and Medicare HMO lives as part of our Medicare submission. All right, and next slide. The last thing I want to say about working with payers is our process for data submission and validation with payers. So we've built out a 3-stage validation process. We also have a technical group that we facilitate that meets monthly that all of our payers can participate in. And we've done a lot of technical assistance and outreach. So we've held office hours, we've done trainings for the payers and their technical teams on how to prepare the data for us. And we've made our team really available for them. And I will say this has absolutely paid off. The validation process has given us a couple of really good steps for gut checking things. We've ended up making some improvements. We're in our second round of data collection this year, and it's already been sort of a drastic improvement over the first year. And then after we go through that validation process, we have an individual meeting with every single one of our data submitters. And that is a lot. That takes a lot of time and a lot of effort for our team. And my team is a little bit like, why are we doing this? But I think it's really valuable in terms of understanding the data, building those relationships with the team. And I will say that between last year and this year, we have seen some payers really engage. We had a couple payers last week or two proactively review their data and prepare a slide deck for that individual meeting so that they could tell us what they wanted to talk about in the data. And we were just really excited to see that level of engagement and participation. So I think it's been a lot of effort and a lot of staff time to build to this, but I'm feeling really pleased with our process and that it's paying off in terms of improving the quality of the data that we're receiving and really engaging with the payers and having them understand what we're doing and what we're after. I'm going to pause here for a second. Any questions about our data submission or our work with payers before I move to accountability?
Hi, I don't know if I can jump in. This is Flo Khan. I'm with one of the commissioners, and I apologize for jumping on late. So if you've already covered this, please just let me know. But in terms of like when you get the data collected from the insurers and it's on various aspects, so whether it's hospital claims or it's pharmaceutical claims or whatever, do you also outreach to those entities to kind of talk through the data and see, you know, if there's to better understand like maybe some of the numbers as well, or is that part of that process for validation?
Yeah, so I'm only talking about payers here, but we have a whole separate parallel staggered process for the providers. So we have about 50 provider organizations in our state that meet our thresholds for inclusion on the provider side. And after we finish validating the data with the payers, we create a state level data file. Then we make data summaries for all 50 of those provider organizations and do a validation process and individual meetings with all of the providers. So yes, we are absolutely having conversations that give context to that data. We have some of our provider organizations, for example, our hospital association, as well as some of our larger health systems. We also have several integrated payer and provider systems. So we have Kaiser and a couple of others where they are both payers and providers. So they participate sort of in the program from both sides. And we meet with them. They participate in our technical group, our office hours, all of those pieces. So yeah, I would say short answer, we're definitely having those conversations and getting that illustration of what's happening from their perspectives. It's just happening sort of in a parallel track One thing that we've learned and are trying to facilitate more of, and probably not surprising to any of you, is there's a real range in the level of engagement between payers and providers. So some payers and providers have a very tight connection because of their contractual relationships. They're sending data every month back and forth. They've already got a lot of insight into what the cost drivers are. They're already receiving lists of high cost patients and members that already exists. In other cases, they have no connection at all. So we are trying to not interfere with any of those really strong relationships, but we're also trying to use our program and these validation and data conversations as an opportunity to build more connections. So a couple of times questions have come up where we've ended up facilitating a joint conversation with specific payers and providers and bringing them together to talk about the data. And we expect that will just only continue in the future.
Great. Thank you so much. Very helpful.
Any other questions? Melinda, you're watching for raised hands.
I am watching. Any other questions? Please raise your hands. Yes, Commissioner Rowe-Dugan.
Yes, thank you. Quick question about the individual meetings to review this data and data submission validation. When you talk about the team is the equivalent of the PPC for you in Oregon, or who is the team? Who's having the meetings and reviewing this data with the payers?
The team is my team, so agency staff. So I have a team of analysts, actuary, and several policy analysts who prepare the data. We will be presenting summaries of the data as well as highlighting specific payer and provider information in the future with our committee, but the committee is not the one doing those review meetings.
All right. Anybody else online?
Yes, Commissioner McAllister.
When you present the data, is it public or is it just to the commissioners? And when is it? Can we listen?
Yes and no and yes. So when we present data for these individual meetings, we prepare a data summary for each payer and provider, and that is confidential at this stage. It's given to them directly for review and discussion, and it breaks out in more granularity than we intend to publicly report. As part of our long ramp up implementation, we also have committed to not publicly reporting payer or provider performance for 2018, 19, and 20. That's our initial data collection. So all of these meetings and conversations that we've been having have been about this data that we are not going to publicly report at that level. Starting next year, probably May-ish, we are going to put out our first payer and provider level report, and that will be public. It will be publicly discussed with the commission. We're still talking about what level of granularity goes into that report and what it looks like. We're looking at some of the other states that are ahead of us for examples. We're talking to our group and getting input about how we should design that report. We do ultimately intend to be publishing fully identified report and data book, but whether or not that's exactly the same as these individual data summary packets, probably not.
Thank you.
Great.
Anybody else before we move to the next item?
Not seeing any other hands, Chair.
Thank you very much on this subject. Appreciate your input. Next item on the agenda is Nevada's healthcare cost growth benchmark, and this is Melinda, your forte.
Thank you, Chair. I did want to recognize Commissioner Winkler. Did you have a quick question before we transition?
It's okay. I can find out later. Thank you. And thank you again, Ms. Bartleman, for speaking with us today.
Thank
Melinda,
you.
if I'm not mistaken, Sarah has additional slides.
Correct. Thank you. Please go ahead, Sarah.
Do I have a few more minutes? Okay, I'll go fast. Okay, so let's go to the next slide. I want to just give a high level of what our accountability measures look like in Oregon. So next slide. As I mentioned, one more. Our original bill in 2019 told our implementation committee to make recommendations about what those accountability measures should be. Our implementation committee spent a while with Michael and his team's help thinking about what some of those options were. And we considered a lot of options, including financial penalties, rate review, price caps, contract review, additional general enforcement. And ultimately, where we landed, next slide, was the performance improvement plan and the financial penalty. And that is what was in our second piece of legislation. So all the links are here if anyone's curious and wants to go look at the details. Next slide. So the way we're really talking about it is that our accountability has three levels, or it's sort of phased in over three buckets. And the first is what we're starting now and early next year with transparency. So that public reporting, whether you want to call that naming or shaming, or just fully transparent understanding of what's happening in the state, especially with as many different players as we have, with 30 plus providers and 30 plus payers and 50 plus provider organizations that we're talking about. There will be a lot to dig into there. Then we have performance improvement plans, and then we have financial penalties. And throughout all of this, I think to the commissioner's earlier question, we have those ongoing conversations to understand the cost growth drivers and the reasons for exceeding the cost growth target in a given year. And one thing that our implementation committee set up early on was an understanding that not all cost growth is bad. Oregon has a number of initiatives that are specifically going to increase costs. We have expanded benefits and coverage mandates. We have expanded coverage to new populations. We are investing in primary care. We are investing in behavioral health. If we see costs going up, if we see healthcare spending in those areas increasing, that's great. And we have to be really careful to make sure that nothing in our cost growth target program is creating an intended or unintentional dampening effect on those policies and other initiatives that we want to see happening across the state. So one thing that our implementation committee did was help come up with some off-ramps before we get to accountability. Next slide. So before any accountability measures might be applied, we're going to do a couple of things. And the first is ensure statistical confidence. So we built out a methodology so that only entities that exceed the cost growth target with statistical certainty may be held accountable. This was in part because we have so many, and some of our entities that are included are small, and we were expecting there could be a lot of swings year over year if just because of small numbers or just because of a couple of high cost patients, and we wanted to make sure that we were controlling for that. Then we have a list that is definitely developmental, but a list of sort of reasonableness or good reasons for exceeding the cost growth target. So only entities that exceed the cost growth target with statistical certainty and without a good reason may be held accountable. So there will be a whole process in which we say, here's the data, you are above or below the target with or without statistical certainty, and the conversation may end there. That's it, done. Public reporting, end of the line. Or if above the target with statistical certainty, then we might get into this reasonableness conversation. And this is a place where we are going to be doing a lot more work over the next 6 to 9 months in developing out further what these criteria are, because we want to provide some clarity to the payers and providers, of course, but also we need flexibility. This is not going to be a formula where you can say, all right, if I do exactly X, Y, and Z, I will be fine. My current example of this is if we had created a very explicit list of criteria in 2019, we probably wouldn't have put COVID on it. We didn't see that coming, and that has certainly affected the health system. That is going to be a reason that explains a lot of the cost growth or a lot of the change that we see. And that's not any given payer provider's fault. That's not something we'd want to hold them accountable for. So we'll be working through that list of reasons, which includes things like pandemics and changes in tax structures, changes in federal law that affect costs, changes in state law. Again, Oregon, it mandates coverage pretty regularly. If that's happening, we would expect to see that trickle through on the provider side costs. Yeah, thank you. Here are some of our potential good reasons. Another really common example is new pharmaceuticals or treatments entering the market. There can be some very high cost treatments coming in, and if those are covered, or which may or may not be within an organization's control, those are not costs that we would want anyone to be held accountable for. We really want to make sure that this program is not being used to deny or create additional access barriers to care. So we want to make sure that there's an off-ramp for that. So this is our starting list. It's broad and flexible by design, but we're also working on creating a little more structure around this. So what are some examples? What's sort of in and out under each of those? And that's something that we'll be doing over the coming months. And those conversations will be public, and happy to share information if anyone's curious or wants to listen in on that. And then finally, last thing I'm going to share on the next slide is our timeline for phasing in accountability. So as we're collecting data, as I already mentioned, we're rolling in the identified public reporting starting next year. Performance improvement plans don't apply until the cycle after that at the earliest. And then the financial penalties would not apply until 2027. Data submitted in 2026, reported and accountability determined in 2027. So we still have quite a long ramp before we get to that point. And I'll stop there. There's a little more information about next steps and links to more information on our website on my next slide, and I'm happy to answer any other questions.
Thank you very much. Appreciate your presentation. So any questions? We're running tight on time, so please raise your hands. Melinda, you want to check on questions?
Yes, please, Commissioner Khan, please go ahead.
Thank you. God, this is really great and really helpful. And so I really appreciate, Sarah, you presenting it. On the slide right before, when you looked at the reasonable, some of the factors that you were looking at, are you going to need to put those in statute? Are you going to be able to have the flexibility on the regulatory side just to make that determination so that you continue to have the flexibility if you see changes that need to be added, or you see, well, maybe we don't necessarily need those?
Yeah, so we will not be putting these in statute. We'll be putting them in administrative rule, and we'll be doing administrative rulemaking next summer with a full public process. I think you're flagging something that keeps me up at night a little bit, like how do you put this in rule in a way that provides some clarity and some guidance, but also is not too exclusionary or that you can't change it in the future. With administrative rule, we can update those at any time as long as we go through the appropriate public process. But I think it's pretty hard to write good administrative rules that just say, and anything else that might come up.
Yeah.
So that will be a negotiation, and that will be a challenge for sure. But I think we're going to try to be striking that balance between providing some clarity and rule, but also leaving that door open for future flexibility.
Thank you.
Thank you so much.
Anybody else?
Yes, Commissioner Van Houweling, please go ahead.
Well, great. Thank you, Melinda. And thank you, Sarah, for the presentation. My name is Commissioner Mason Van Houweling. Just by background, I run the large public hospital here in the state. So I appreciate the presentation. Question certainly around accountability. And I think, the goal and the charter of this commission is how do we protect patients and this particular area's access and cost. And as you know, there's a lot of cost shifting that happens in the industry. And in particular, when it comes to the commercial and self-insured. And then I personally, also being a large employer in the state with over 4,000 employees, we see our cost of health insurance continue to go up on one of our line items in our expenses. And as you heard from Mr. Kelly, a lot of the things that we're seeing are out of the provider's control, whether it's food cost, supply cost, labor cost. I know, and just even power cost, every hospital in the state, pretty much in the South, got hit with new tier rates and over budget in their power expense. But how do you see, and how is Oregon handled ultimately? If you follow the dollar, and I know everyone in this commission is really looking at the pocketbooks of Nevadans and the out-of-pocket expense, whether it's co-insurance, co-pays, deductibles, and when I go back to cost shifting, a lot of that just falls back on the patient. And sometimes, and we've seen over the years, patients avoid preventative medicine, screenings, mammograms, just, primary care visits. So how do you hold, to protect the pocketbook and the dollar coming out of the employers that, negotiate these plans, but ultimately the patient that has to pay the expense at the end of the day? How do you protect that amount? Because I know we're trying to, again, slow down the growth and slow down the cost. But if we're at the end of the day, if we're not, the out-of-pocket expense, and I'm talking, those that are uninsured for one, and then two, that we know that there's a lot of uncompensated care or what's called bad debt expense related to individuals' co-pays and deductibles. So how do you really, when it comes down to accountability, ensure that doesn't, all these factors that are going on doesn't hit, the employer, which is the most important, because often that's passed on to your average worker. And I'm just curious on how you've had that discussions and try to protect the patient at the end of the day, regardless of all this activity. And there's a lot of things that are very sophisticated and complicated. And we know a lot of the governmental rates are set already. So we're looking at that 25% that really is where the cost shifting happens. So I know that's a long question, but my goal is how do you protect the average Nevadan from continuing to add another zero to their deductible next year, so they don't have to feel the cost?
Yeah, that is a fantastic question. I think really gets to the heart of a lot of this work. I could probably talk for an hour just about some of the what we call monitoring for negative impacts of the target and our charge to look at quality, access, and equity as it relates to it. So a couple of things. I don't have a good clean answer on this, but I think just a couple of things for your consideration. Our program is also explicitly charged with measuring and monitoring negative impacts. And that includes things like what is the impact on the consumer. Our program put out a report earlier this year that specifically looked just at impact on people. So looking at some of those cost sharing, increases in premiums, deductibles, all of that. This is a tricky thing to message, which you've probably already wrestled with as commissioners and trying to explain this program locally of we could succeed. We could hold healthcare cost growth down. We could meet the target every year and premiums or deductibles might still go up. And how do you reconcile that and explain that to the consumer? The target does not apply. The benchmark does not apply to premiums. And that's tricky. That is an ongoing challenge we are having. I'm sure you're experiencing as well. So I think what we're doing is taking this monitoring aspect. So it's not something that's baked into our methodology. It's something that we're doing supplemental and trying to tie in all of the conversations and reporting. So we do publicly report and will continue on what's happening with patient cost sharing. We have a whole hospital reporting program that reports on what's happening with charity care, and we want to weave all of those together. We really see the cost growth target program as providing the umbrella sort of communication to tie these pieces together and give a more holistic story of what's happening in the health system and how that translates to the patient or the consumer side. We are doing some additional analysis of what's changing. So we measure allowed amounts, not to get too wonky, but how much of the patient cost sharing or how much is that shifting over time? We are tracking what's happening with premiums, deductibles on the commercial market. We're also looking at sort of uninsured and how, so there's just a lot that we can look at and put it all together. It doesn't create a fix at all. Like I won't claim that, but it does help create a more comprehensive picture and it helps us ground in why we're doing this work and why it's ultimately important.
Thank you very much. Any other questions?
Yes, Commissioner Winkler, please go ahead.
Hello, and thank you again for speaking with us. And I appreciate your last answer because I was also interested in ultimately out-of-pocket costs, and that is definitely a hard thing that we're trying to address. But if I could just get into some logistics questions, it sounds like besides your like state health agency, there's a few different committees that provide input and get reports and things. Can you kind of name those or how that works?
Yeah, so the program is housed within the Oregon Health Authority and my team staffs the program. We have an external public advisory committee that's equivalent to you as a body. They're a public group. They meet currently about every other month. And it's a 20-member committee, public, private, payer, and consumer representation. And they're charged with a number of things specific to the program, setting direction, setting the target, hearing presentations on the data, identifying strategies to mitigate cost growth, making additional recommendations for policy action, all of those types of functions. As a committee, they are not responsible for collecting the data, reviewing the data, or making the determination of accountability. And that was something very specifically that we carved out because we didn't want to create conflict of interest issues for committee members. We wanted payers and providers that were part of the program and subject to the program to be part of the committee. And so we made sure that there wouldn't be that conflict of interest. I know that's not a choice every state has made, so that definitely varies. But in Oregon, we wanted the payers and providers who would be subject to the target to be part of the committee. And so they are not responsible for determining accountability. That rests with the state agency. And then I also mentioned our technical group, and that is an ad hoc, open to anyone, sort of a y'all come public meeting that we hold once a month. It's mostly focused on the payers and their data submission or their data analysts. So it's not a decision-making group. It is a space for troubleshooting. We provide information, space for questions, and my team staffs that as well. Oregon has a lot of committees and we try to connect the dots between committees. So for example, our agency has a health equity committee and we've consulted with them on some work. We have a quality measurement committee. We've consulted with them on some work. So there's a lot of coordination happening, but specific to the program, it's our implementation / advisory committee and then our technical group.
Thank you very much. I think we're running really tight on time. Any other really compelling question from anyone?
Seeing no hands, Chair.
Thank you very much. Thanks for your presentation. Very informational for sure. So we go on to the next item. I think that's your item, Melinda, Nevada's healthcare cost growth benchmark data update.
Yes, thank you, Chair. So now I'd like to transition to another update on where we're at with our healthcare cost growth benchmark work. You'll recall at the last meeting, I had mentioned the baseline data request to Nevada health insurers this past May. Now that we're in fall, I wanted to give you an update on where things are at with the data submissions. Next slide. For background, you may recall that the state had submitted a letter back in April to Nevada health insurers, noting an upcoming informational webinar regarding the baseline data request, as well as another webinar to gather health insurer input on truncation point guidelines. The informational webinar was held on May 16th. This gave an outline of the data request, distributed data specification, data specification manual and to Nevada health insurers, which gave the details for how to submit the data to the Department of Health and Human Services Office of Analytics team. So that's here in Nevada. And it gave an opportunity for any initial clarifying questions from the health insurers. During the webinar, the state requested all data submissions by August 30th. The Office of Analytics has now begun those data validation communications with the health insurers for all data submissions as of October 3rd. So that team is doing a really awesome job in communicating with the health insurers, making sure that their data is as they wanted it to be submitted and is accurate and all of that good stuff. Next slide, please. As noted in the data specification manual, the following Nevada health insurers were requested to submit aggregate de-identified data for Nevada's baseline benchmark analysis for the following types of plans. As you can see in the shaded cells, some data was not requested for some plans because the state was under the impression that they were not operating in that particular market. However, the Division of Insurance has since informed us that Centene and Renown are, in fact, operating in the Medicare Advantage market, hence the asterisks in those cells. Next slide. This table summarizes information provided by the Office of Analytics on the status of data submissions from Nevada health insurers. I am happy to report that all insurers except for Aetna, who requested an extension, have submitted data. Some insurers are currently preparing resubmissions, and our analytics team has been working with all health insurers to address any questions they have and to provide technical assistance related to the data request. So really good communication there. I've indicated in red information that was requested of insurers, but which they did not submit. I'd like to quickly review the status of submissions by insurer, if I might. As noted earlier, Aetna requested an extension to submit its data. Anthem successfully submitted complete data for all 3 markets in which it operates. Centene did not submit spending data for its self-insured commercial business as requested. Most employer-based commercial healthcare coverage in Nevada is self-insured. Centene also did not provide aggregate partial claim spending. So partial claims are claims that are paid for self-insured employers who carve out a benefit, most often pharmacy. Cigna successfully submitted complete data for the 1 market in which it operates. Humana did not submit aggregate partial claim spending for its self-insured commercial business as requested. It also did not submit Medicare Advantage spending data as requested. Renown did not submit aggregate partial claim spending for its self-insured commercial business as requested. And finally, United Healthcare did not submit spending data for its self-insured commercial business, nor aggregate partial claim spending as requested. So in summary, our state's largest insurer, United, has not submitted self-insured commercial spending. Centene has not submitted self-insured data, and Humana has not submitted Medicare Advantage data. However, we do remain very hopeful that they will submit this data in the future, and they've been very collaborative and communicative with us on this request. And we just remain hopeful that they will support the state's request to improve transparency and affordability in our healthcare system. So with that, I just wanted to pause if there were any questions from the commission.
Yes, go ahead, please, questions.
I am not seeing any questions, Chair. Oh, I do. Commissioner Khan, please go ahead.
Thank you, Melinda, and thank you for this. Just one question. So for those that have not yet submitted, what is the timeline that you have? I know you said that you're hopeful that they will submit, but have you given them a new timeline, or are they still within the timeline?
Sure. So some have requested an extension, and for some of them, they have submitted all of the data that they wish to at this time.
Okay, thank you.
Sure.
Thank you. Any other questions? If not, we can go to the next item on the agenda. The presentation of options for healthcare cost growth mitigation strategies, rate review. Again, I would humbly request that please keep in mind the times allocated include question time. So please proceed. This is coming from Melissa Wangley.
Thanks, Chair. I just wanted to introduce this topic really quick, if I might.
Sure.
So now we're going to move into the last two topics on mitigation strategies that are associated with our benchmark. And those are rate review and all payer value-based payments. So as we listen to these last two presentations on potential mitigation strategies, I would just encourage the commission to think about what strategy or strategies might work best here in our state, noting that this would most likely be more of that phased in approach and not immediate, and to be thoughtful of perhaps 1 to 2 strategies that the commission might want to gather more information on for further consideration during 2023. Since Nevada is still truly in the planning stage, we really have the opportunity to mold our benchmark program into something that will work best for Nevada's healthcare system, our patients foremost, our providers, and our health insurers. We're still setting up the program in an operational way to complete all the little baby steps to get up to that point takeoff. Once we get off the runway and into the air, we really want this program implemented in the very best way for Nevada. So with that, I'd like to hand it over to Michael to give a swift overview of some accountability mechanisms that were already discussed, coupled with a quick discussion, and then moving into the last 2 options for our mitigation strategies discussion, the rate review and multi-payer value-based payment. Thanks. Michael, go ahead, please.
Thanks. Melinda, we're going to start with rate review as our first topic. So I'm going to invite Alyssa to present, and then I'll take the second topic.
Sounds good.
Sure. Thank you, Michael. And thank you so much, Melinda. Good morning, commissioners. It's so nice to be with you today. So I'm going to start with the topic of health insurance rate review. And as a quick overview, what is health insurance rate review? It's a mechanism that allows state regulators the opportunity to review and in some cases disapprove or modify proposed health insurance rate increases. Rate review is typically a function of the state's Division of Insurance, DOI, which is how I'm going to refer to it for the rest of the presentation. And it's important to note that the rate review authority of DOI can only be exercised over the fully insured market and not the self-insured market. We're talking about rate review today because it's an important strategy that can be used to push down premiums in state regulated health insurance markets. And I also want to spend a minute on the terminology, which can be a little tricky here. So the word rate refers to the price of a health insurance plan, and the rate changes, which typically occur on an annual basis, can take the form of increases, decreases, or stay constant. DOI reviews the rate changes in this process, which can also be referred to as the base rate. And then the health insurance premium is determined by applying what are known as rating factors to the final approved base rate. And under the Affordable Care Act, only 4 rating factors can be applied, which are age, geography, family composition, and tobacco use. So that's the difference between rate and premium. I also want to note that the Affordable Care Act provides essentially a floor for the rate review process. It requires health plans to file and publicly justify the reasonableness that proposed rate increases in the individual and small group market over a certain threshold, which is currently 15%. And then to varying degrees, states have additional authority and regulatory, statutory and regulatory authority to regulate health insurance rates. Next slide, please. So why do we want to focus on rate review here? So first is that it's it can be used as a tool to make healthcare more affordable for both individuals and businesses in the state. And we know that healthcare affordability concerns are significant for Nevada residents. According to the recent Nevada Consumer Healthcare Experience State Survey, CHESS, which you all heard about during last month's meeting, almost 2/3 of respondents from that survey reported experiencing at least one healthcare burden in the past year, and 83% worried about affording healthcare in the future. In that survey, over half of all respondents reported delaying or going without healthcare during the prior 12 months due to cost. In addition, a recent national report from the Commonwealth Fund showed that Nevada is among the top 8 states for the highest average employee share of premiums as a percentage of median state income in 2020. And Nevada is one of the top 4 states where workers were responsible for 37% or more of their family premium. Now, it's important to keep in mind that while the rate review process does not dictate how much of the insurance premium is paid by the employer and how much employees are responsible for, we know that one way that businesses can respond to escalating healthcare costs is to shift a higher percentage of the premium onto employees, or to transition to health insurance plans that have higher deductibles and other cost sharing in an effort to keep yearly premium increases lower. Next slide, please. So the 2 following reasons to focus on rate review is that it can help with overall cost containment efforts by pushing payers to push providers to bring down the total cost of care. For example, it can help give payers additional leverage in contract negotiations with providers, and it can also be used as an enforcement mechanism for cost containment initiatives, which we'll discuss later in the slides. And finally, rate review can increase the transparency of healthcare pricing and costs when there's more publicly available information on the reasons and justifications behind rate increases, which can also be used to educate consumers on what's driving health insurance premium increases. Next slide, please. So in order to understand what the potential opportunities are to strengthen the rate review process in Nevada, we wanted to start out with an overview of the current authority and process. Nevada law requires prior approval by DOI for any individual or small group rate change. The DOI is authorized to approve, disapprove, and modify proposed changes. And I just want to note that not all states have this prior approval authority, so that's certainly a strength of the Nevada process that can be built upon. The DOI considers a number of factors when determining whether a proposed rate is justified. Those include past claims experience, which reflects the total cost of medical care and prescription drugs; utilization, which is how often enrollees use medical services and prescription drugs; and the insurer's history of rate changes, its financial condition, administrative costs, profits, and other sources of revenue, and other factors used to justify proposed premium rate changes. The public may also submit written comments to DOI regarding proposed rate changes, which will be considered during the rate review process. Next slide, please. DOI has 30 days from the date that the rate change application is complete to either approve, modify, or disapprove a proposed rate change. And DOI may make such decisions if the rate is determined to be excessive, inadequate, or unfairly discriminatory. I also want to note that on the DOI website, there is information available to the public that I think is really useful in understanding the process. There's a great video explaining the rate review process, and there's an online search tool that enables the comparison of proposed and approved average rates for each plan, as well as redacted actuarial memos and rate change justifications. Next slide, please. So these are the 4 main categories of ways that we'll talk about today to strengthen the rate review process. One is to strengthen the statutory authority for DOI. The second is to strengthen the stakeholder and public engagement in the process. The third is to build alignment of the rate review process with other cost containment initiatives. And the fourth is to improve monitoring for impact, not just on affordability, but also access, quality, and equity. Next slide, please. So starting out with strengthening the rate review authority, one way to do so is to enable DOI to consider the public interest or affordability or other such similar criteria in its determination of whether to approve, modify, or reject proposed rates. And this would be in addition to and not in place of existing standards and criteria, and can help ensure that considerations of affordability are taken into account when determining whether to approve, modify, or disapprove. Another option is to for the DOI to obtain authority over a larger portion of the health insurance market. So most states, including Nevada, have limited the rate review to the individual and small group market, small group being defined as employers with 1 to 50 full-time employees. However, the large group fully insured market, so with greater than 50 employees, comprise a substantial portion of covered lives and also face substantial rate increases. So authority could be extended to reviewing large group rates. I'm happy to take questions, Commissioner Winkler, or
Sorry, if you wouldn't mind, because I was just wondering if we have an
Yeah.
idea of, so then what payers does that actually affect in their health plans if we're only at individual and small group plans? Do we know?
Are you saying that the number of payers or the names of the payers?
Sorry, I mean, if we're not looking at large group, fully insured plans, how many insured lives are we missing?
Yeah, I don't have that number offhand, but we can certainly do some digging. And I would imagine that DOI tracks that information because they're tracking the fully insured market. So we can look into that too for you in terms of how many lives are in the small group versus large group.
Yeah,
Or if anybody else has that
I-
information, feel free to, yep.
This is Dr. Khan. I believe it's over 50%, and it may be higher than that, which is beyond the small employee or individual market. Because the bulk of the industry that we have is the hotel and casino industry and the unions, and that forms a bulk of the payers.
Right. And then again, I think it's important to think about the fully insured large group versus the then self-insured large group, which would not be subject to state level rate review. But we can certainly, we can follow up and get a breakdown of those.
And not to miss the managed Medicaid products also.
Good question. Thank you, Commissioner Winkler. Okay, so to finish off this this slide, the third consideration for potential statutory changes is to ensure that the state has sufficient and sustainable funding for rate review operations over time, recognizing that additional resources may be needed, especially if changes are made to the program. So this could be achieved, for example, through requiring regulated entities to pay an assessment or user fee to support the cost of reviews. Yes, Commissioner Khan.
Yes, thank you. I have a question and or concern about the term affordability. The concern would be if you artificially cap a premium or a rate increase because of affordability concerns, and those are legitimate concerns, then aren't you just like cost shifting? Because if it's artificially like established from a rate just to keep it affordable, there's still costs associated with that care. And so are you just cost shifting to other areas?
Sure, so I'm
Especially
happy
if you've
to
only
offer
got-
a response, and then I would welcome others too, and we can talk about this more at the end during the discussion too. So I think one of the reasons that we would think about incorporating affordability in addition to the other factors is because you still certainly want to take into account the other factors that are being considered as to why the rates are increasing, and those include underlying costs in terms of provider costs, pharmaceutical costs, et cetera. So I think that needs to be taken into consideration holistically, and affordability would be one of the things that the DOI would take into consideration, as well as the other sort of underlying reasons why rates are increasing year over year. And then I also want to just say briefly that that's why rate review is one of the strategies for affordability, and why it's also important to think about strategies such as the cost growth benchmark and other ways that we can be looking at cost growth across the system, and that this is a strategy that can work as complementary to other potential strategies that Nevada is considering and currently implementing.
And I guess I get that. And I think, you know, to your second point about who actually rate review currently within Nevada is actually covering, because to the other Commissioner Khan's point too, is like, we're only looking, currently they only have authority over a very small portion of the Nevada like insurance market, right? But there's a huge portion, both large group and then self-insured, that are actually the largest, right, in Nevada. Those are your largest groups in Nevada who are outside of this market. So if you look at just rate review in that context, then there would be a lot of cost shifting that could potentially occur. So you know, it does seem to me like one of the things to really look at and focus on is expanding the authority for DOI to look at other markets, because those markets are actually larger.
Thanks for your comments. Okay, so moving on, I think, to the next slide. So the second ways to think about improving the process is to focus on the stakeholder and public engagement. And as I already said, Nevada DOI does provide information online around the rate filings and allows for public comment. So this is a good starting place. And there are some additional potential ways to enhance transparency and engagement, which can include additional materials on proposed rate changes, recognizing that the rate filing materials can be quite technical in nature. So some other states have essentially included more consumer-friendly summaries of the proposed rate changes and justifications and what that all means, so that people can then respond via public comment. In addition, some states have shared the questions and challenges between health insurance companies and the DOI in the rate negotiation process, which can provide some additional context. Public informational meetings or hearings is another way to increase public dialogue over proposed rate changes, which a number of other states, again, have implemented these strategies. And then right now, again, Nevada allows for written comments, but this could be an opportunity for there to be oral comments provided as well. And then engaging stakeholders, which in this case could be insurance companies and could be other stakeholders as well. Holding additional public meetings could be a way to have, again, more sort of open dialogue around why rates are increasing at the rates that they are, and the justifications behind those rates, as well as potential affordability concerns. Next slide, please. The third way here is to build alignment with other cost containment initiatives. So one way to do this is to collect information from insurers about the impact of specific cost drivers and strategies the insurers are implementing related to affordability through the process, as well as information about provider prices and price variation. Insurers can include this information in their actual rate filings to DOI, or in some states, DOI has the authority to review payer-provider contracts, which can reveal additional in-depth information. Then if Nevada opts to pursue some other affordability goals, such as primary care spending investments or value-based payments, which we'll hear about later, or others, the rate review process could be used to obtain information on progress toward those goals. And I will just know, I know we'll be discussing primary care spending later in the meeting, but that in Delaware and Rhode Island, enforcement of their primary care spending targets occurs through the rate review process. Next slide, please. And the final area is for improving monitoring. So this can take the form of monitoring for impact on access, quality, and equity. And because rate review can create downward pressure on rates, the state could monitor for potential negative impacts on consumers, such as impacts on access to care or member experience. So monitoring could include looking at insurer networks, appeals and grievance rates, and topics, health plan performance on quality and patient experience measures. And equity can also be a key objective in the state's approach to monitoring. For example, the state could examine disparities in who does or does not have access to affordable health care coverage when tracking the program impact. The savings from the program could also be monitored and documented over time to ensure that it's working and is having an impact on affordability. And then equity can additionally be built into the process by asking insurers to report on the cost and quality initiatives that they're undertaking to advance health equity goals, as well as ensuring that any stakeholder engagement includes proactive outreach to diverse communities, which could also happen through an advisory committee or other structure. Next slide, please. So this is one example. I would say Rhode Island, a couple of states, again, do incorporate a lot of these strategies that I just went over, but I wanted to give Rhode Island as an example here of a state that does have a robust rate review process. So Rhode Island does have a separate entity, different from their division of insurance that regulates other lines of insurance, but this just regulates health insurance, called the Office of Health Insurance Commissioner, OHIC. OHIC has the authority to review large group policies as well as individual and small group, as we talked about before. OHIC has the authority to require submission and allow review of provider payer contracts. OHIC has a broad charge to protect the public interest and improve the healthcare system as a whole. And this applies to the rate review process and has and is shown to be sort of informing the OHIC's ability to take into account affordability in reviewing rates. They have a highly transparent stakeholder engagement process with regular public meetings, opportunities for both written and oral comments, and an ongoing advisory council. And they use the rate review process in a way that's tied to broader affordability goals, including the adoption of value-based payments, primary care spending, and provider price growth caps. Yes, Commissioner McAllister.
At a future meeting, I would love to hear more about how long OHIC has been doing provider payer contract review and what that impact has been.
Sure, I will note that. Okay. Next slide, please. So a quick summary here. States can make either incremental or more sweeping changes to the rate review process, as you just saw. There are a number of ways here that Nevada could think about some specific reforms to your process. Some of the potential opportunities that sort of jump out are adding affordability to the public interest, adding affordability or public interest criteria to the process, expanding to the large group market, and then enhancing some of the transparency and public engagement efforts through additional online materials or and/or public informational meetings and hearings. And I do want to acknowledge that all of these efforts do take additional staff and resources and need to be sustained over time. So that all, of course, must be taken into consideration when thinking about potential changes. So we'll turn now over to some discussion questions, and I'm happy to take more questions from anybody here, but is whether this, and next slide, Michael, please, whether this is something that Nevada is potentially interested in pursuing, or whether you think it's worth pursuing further, if there's any further information that would be useful to hear, and I've made notes of the request thus far. So I'll open it up to the group. Yes, Commissioner Winkler.
Thank you. So this is something I'm particularly interested in, and it was one of my original submissions for our BDRs.
Mm-hmm.
And I guess it's just for our commission generally, but I would like to hear from our Division of Insurance Director, Barbara Richardson. I know she attends our meetings pretty frequently, and just get from her how the rate review process looks now, where she thinks there are positive aspects to it, where it's failing, what she thinks of her agency implementing and strengthening their powers to review everything. And one of the things, so I guess I just wanted to ask that public interest criteria, I think, would that also encompass those accessibility and equity things that we also want to include with the rate review process?
It certainly could, and I'll just note, in some cases, that's taken into account because the Division of Insurance, or the sort of regulating entity, has a broad authority in their charge to think about affordability and public interest overall, and/or it can be applied more specifically in terms of the criteria that's being considered when reviewing rates. And certainly that states can tailor it to incorporate things like equity as well.
And so I guess I'd like to echo Commissioner McAllister that we'd like to hear about Rhode Island work they did, and I believe Mr. Baylett did a lot of work on that, so perhaps he would be able to kind of elucidate that. I guess one of the things I'm interested in is how do you set standards for affordability, or does Rhode Island do that? Is it a case-by-case basis?
So Alyssa, I can help with a couple of questions.
Sure, go ahead and then yep.
Yeah, so I'll answer them in reverse order to how they were asked. First, in terms of how they apply affordability standards, what the Office of the Health Insurance Commissioner in Rhode Island has done is to create a set of affordability standards. They were originally developed in collaboration with an advisory committee, the standing advisory committee to the commissioner. There were originally 4 of them. They have changed over time, but they've included advancing adoption of the patient-centered medical home, investing in primary care, the price growth caps that we talked about previously were part of the affordability standards, and setting expectations for adoption of value-based payment. All of those fell within the affordability standards that were developed by the Office of the Health Insurance Commissioner in collaboration with, at the time, his advisory committee. But I will say that they are dynamic. I think that the affordability standards have now been updated 4 times since they were created about a decade ago. So the office has opened them up for both refinement and in some cases more fundamental revision on a fairly regular basis. In response to the earlier question about the review of provider insurer contracts, I've seen this used to 2 effects. One has been for the office to get a better understanding of the business relationships between insurers and providers, and specifically understanding the nature of the payment terms that they are adopting in their contracts. Further, I know that the office has used contract review to assess insurer compliance with the affordability standards. So for example, the contracts were examined to assess whether insurers were adhering to the price growth cap. The state also has a required aligned quality measure set so that insurers aren't all using different measures in provider contracts. And so the contract review was used to confirm compliance, or I should say adherence to the aligned measure set.
So this is Dr. Khan, a comment based on what's being proposed or suggested or implied in this presentation and the previous presentation. One has to keep in mind of the unintended consequences. You may squeeze whichever way you want, somebody is paying for it. At the end of the day, that limits the access for the patients, which is the responsibility of this commission to recommend options. Having said that, the insurer raises the premium, that's extra money to them. They go down to the providers, the hospitals and doctors and post-acute facilities to negotiate a lower rate, which is almost never compatible with the inflationary rate, and sort of a pressure on the hospitals in particular to negotiate a lower rate every year or every 2 years at the time of renewal of contracts, which doesn't match the inflation rate. I think Commissioner Van Holling alluded to it, the inflationary impact of multiple factors on the providers, especially the hospital, whether it's the employee cost factors, supply cost factors, multiple areas that the hospitals have to engage in purchase of services or products. None of that is taken into account, and yet the middleman, the insurer, is raising the premium, negotiating lower rates with the providers, and on top of it, denial of services by barriers of prior authorization, which takes forever, or just pure denying an MRI or denying a consultant or denying a specialist. So that's another saving. So all that goes into one pot. And we are focused on the provider rates and provider cost and growth of provider rates. So I think we have to be very cognizant. There was a study that a friend of mine shared with me that at this rate, 50% of the hospitals in the country may go under in the next few years. I mean, one has to keep, that's a huge number, whether they're small hospitals, medium hospitals, or large hospitals. That creates a massive barrier to access. So the access is important, but I think we are focusing too much on regulation of the wrong areas. That's my input.
And Chair Khan, I would respond that my experience is that with rate review, that a fair amount of focus is at looking at the profits or contributions to reserves of the insurers, and trying to ensure that the rates that are developed are not in excess of what is required. So I won't say that there's never any impact on provider contracting, but I think a lot of the impact is focused on the admin and margin charges of the insurers.
That may be true. I'm just raising a point where the access of patient could be very seriously hurt if this data that was in the study says 50% of the hospitals may not be able to keep their doors open. I mean, that's a serious concern.
Sure.
And
Yeah.
focus on that.
Yeah, no, of course, it's a huge public concern. I just don't think that, I think that insurance rate review is focused more on whether the rates, the premiums that the insurers are seeking are reasonable, with special scrutiny to the margins that might be generated and the admin costs that are being charged. So but I don't disagree with your point that losing 50% of the hospitals would be disastrous.
Okay, anybody else has a question?
Yes, I see Commissioner Khan. Please go ahead.
Thank you. It's not so much a comment, just a question, or not even a question, just something I'd like to see. I agree with Commissioner Winkler that it would be helpful to hear from our current Department of Insurance on what do they feel like in terms of how many rate requests have they denied or felt like they couldn't deny because they didn't have the authority to actually move forward. So, and what was the criteria that they felt that they were missing in terms of making that determination? And so, one, just better understanding, have they been able to, and have they denied rate requests in the past? If not, what were some of the limitations they felt that they, like I said, they couldn't? And then also just looking at, you know, again, the marketplace, like what are we looking at in terms of their authority, where they would like to see their authority grow in terms of some of these other markets? And do they have the capacity, quite honestly, to take that on from a resource standpoint? So those are some of the questions I would have and want additional information on before moving forward on anything.
Thanks. I also see our Executive Officer for PEB, Laura Rich. Please go ahead.
Thanks, Melinda. So I don't think I'd be fulfilling my role as an ex officio member of this group if I didn't put my thoughts and concerns on the record. First, I just want to say that the data collection piece of the cost growth benchmark is something that's vital to the PPC, and as the PPC considers those policy recommendations. And the Public Employees Benefits Program is glad to be a part of this, but I think that some of the strategies that are being presented today have the potential of being problematic in our state. I know that at PEB, we are constantly dealing with balancing of lower costs versus having greater access, because our access issues in our state are very significant, especially in Northern Nevada and even worse in the rurals. Nevada consistently ranks 48th, 49th in providers per capita, regardless of if you're looking at primary care or specialists, we're always at the bottom. Rhode Island is in the top 5. Oregon ranks in the top 20. People in those states are not competing for appointments like we are here in Nevada. And when it comes to healthcare spending, Rhode Island is 13th, Oregon is 28th, Nevada is 49th. Nevada spends less on healthcare spending per capita than almost every other state in the nation. We all want to reduce costs. I know PEB is in this. We're always looking for ways to reduce costs, and keep in mind, PEB, we don't have shareholders. We don't have, we don't have those, we don't get big fat bonuses, right? We're public employees. So my concern is that simply looking at this problem in a silo is going to worsen the healthcare access issues that we have in the state, similar to what I would echo Chair Khan's concerns were. So I just wanted to provide just a couple examples that I think that illustrate our problem. Recently, PEB transitioned to a new third-party administrator, and we had some coding snags and claim processing delays. And providers were telling our members, that they wouldn't schedule them, and that PEB wasn't paying their claims timely, and so our people were not able to get appointments. Members were contacting PEB, pleading for us to resolve this problem because they had no other options. They couldn't get appointments elsewhere. I also had several providers contact me personally, and they reminded me that they were dealing with this only because they felt like they had an obligation to their patients, because the reality was that they didn't need PEB because they had a months-long waiting list of other patients that needed to be seen. So imagine being one of the largest health plans in the state and being told by providers that your business is not essential to their existence and their success. It shows that Nevada, until Nevada manages to increase its pool of providers, health plans don't have a lot of leverage. The other example I wanted to share with this group, it relates to our spend relating to our unique geography. PEB has a reference-based pricing model for hip and knee surgeries. We incentivize members to get those surgeries done at certain locations where we've determined the quality is high and the price is low. So for example, out in the rurals, those rural hospitals can be charge $80,000 plus for that procedure that in Reno would be $20,000. So the question is the hospital out in the rural out in those rural areas, are they gouging people, or do they inherently have higher costs because of the lower population that they serve, because of their rural setting? Their overhead costs are having to be spread out over a smaller group of people. If it's the latter, then the cost saving measures that health plans like PEB are using are just going to further drive up those costs in the rural hospitals, because they will have to spread out their overhead among fewer patients. And if enough health plans do this, then things are just going to get more expensive in the rural. So we have that rural situation, that our geography is different. Oregon presented some examples for excess cost growth. Two of them were investments in public health and equity. I just think we have a major access problem in Nevada, and this is something that this group should keep in mind as the suggestions and recommendations are being considered.
Thank you very much. I think in the interest of time, there are still two more presentations. Any compelling questions still?
Commissioner Winkler?
Hi, and I apologize, Commissioner Khan. I think we have a good amount of time to discuss these very serious issues related to our charge. But I want to just clarify, because my understanding of a rate review process would be an insurer wants to raise premiums. The Division of Insurance would then look at their plan, and they would see how affordable it is to the members currently, and looks at what are they able to access with that plan. And so issues of what hospitals they could go to, or what services they could receive would be taken into consideration when evaluating if their premiums actually matched with that. I think that's what's trying to get to what Ms. Rich was describing, and perhaps that isn't sufficient. I don't know. Thank you.
Thank you. Anybody else? Melinda, do you see anybody?
Seeing none, Chair.
All right, thank you very much. I think this was a good, robust discussion. Appreciate everybody's input. So moving along to the next item on the agenda is presentation of options for healthcare cost growth and mitigation. Michael Bailiff.
Thank you, Chair Khan. So this is, I think, the last of the cost growth mitigation strategies we've been presenting to all of you over the last 3 meetings. And we're going to plan on pulling them all together and asking you whether you have interest in any of them. This list of cost growth mitigation strategies is drawn by those being pursued in other states. Laura made a good point that Nevada circumstances don't look the same as some of the other states. And so maybe some of them or maybe none of them look good to all of you as cost growth mitigation strategies. Our purpose is putting them in front of you so that you understand them and can evaluate them. So this last one is multi-payer value-based payment. And let me talk about first, what is a multi-payer value-based payment? Value-based payment is a strategy by which healthcare purchasers and payers use payment as a vehicle to hold provider organizations accountable for quality and cost of care. And when I say quality, I'm using the term broadly to talk about processes and outcomes, as well as access, patient experience, and equity, and any other valued attributes of care. Advanced value-based payment models are those value-based payment models that might transfer some risk to a provider organization and may or may not include prospective payment. Value-based payment models are potentially a cost growth mitigation strategy because they can use a budgeting mechanism to apply to payment. Fee-for-service payment has no budget. It's a volume incenting payment model. So some of these value-based payment models define a budget prospectively and then apply financial consequences for whether the budget is met or exceeded. In states that have pursued value-based payment models, they are most effective when multiple payers align around a common model. So that can be multiple payers both within and across the Medicare, Medicaid, and commercial markets. And so that's what we mean by multi-payer value-based payment. It's a number of payers potentially across markets, but certainly within a market who align around a common model. Oregon and Rhode Island are 2 states with cost growth benchmarks that are pursuing this strategy. Sarah Bartleman made brief reference to what they're doing earlier today. I'm going to give you a little bit more information. There are also non-cost growth benchmark states that have done this. One example is Arkansas, where the dominant Blues plan in the state and the Medicaid agency collaborated on an aligned value-based payment model that included a primary care model and an episode-based payment model. So these are examples of what I would term advanced value-based payment models. Hospital global budgets, that's obviously a payment model specific to hospitals, involves defining prospectively a budget and then adjusting the budget over time based on changing demographics, market share, and service mix. Payments can be prospective or retrospective. This model's been in place for well over a decade in Maryland. It's also in use in Pennsylvania, and Vermont and Rhode Island are currently pursuing it. Episode payment, I just described something that was done in Arkansas. It's been done in Tennessee and in Ohio in broad scope. Specialty capitation is paying on a per patient or per member per month basis, but specifically to specialty providers for certain conditions such as oncology or nephrology or behavioral health. Global capitation is prospectively paying a usually large provider organization for the total cost of care or near total cost of care. And then last, and what's pretty commonly used, especially in the Medicare program, is a total cost of care model with shared savings, where there's a prospective budget, claims are paid on a fee-for-service basis, and then there's a retrospective reconciliation to the budget with any earned savings shared with the responsible provider organizations. So there are examples of multi-payer approaches using all of these value-based payment models. I'm listing them here simply as examples. Where these designs are pursued, there are typically a number of key decisions that have to be taken if the design is to happen in a collaborative basis. First, starting with some assessment of the readiness of the provider system for any of these models, setting some common goals that would be shared across the participating payers and ideally purchasers and providers and consumer organizations. And then selecting and designing at least one payment model to be employed, making a decision on whether this is going to be applied on a voluntary basis or not. So, for example, Medicaid could say, we want to require all of our Medicaid MCOs to do this, or could leave it as an option. There's a key decision in how aligned the model is. Is it the exact same model? Or does it share some general principles, or is it something in between, where there's some common model elements, but also some room for variation by payer? Usually there needs to be discussion of how to support providers so that they succeed under the new model. And then, of course, there needs to be monitoring and evaluation of performance. So I want to look at a couple of examples. I referenced Sarah and Oregon. As she said, they adopted a voluntary value-based payment compact as an offshoot of their version of their PPC. They felt that advancing adoption of advanced value-based payment would help them meet their cost growth benchmark. And so their compact, which was established last year, set forth principles and yearly targets for participating payers, I would say, and providers to meet, but the targets are to have a certain percentage of payer payments under the advanced payment models. And Sarah indicated they had broad participation in the compact. 47 payer and provider organizations covering 73% of the state's population signed the compact last fall. They set their targets around something called the Healthcare Payment Learning and Action Network's alternative payment model framework. So this is a way of categorizing value-based payments, which are sometimes referred to as alternative payments. And so the compact sets specific quantitative targets for payers to have all of their payments under advanced payment models 3A. So 3A is a shared savings arrangement over time, and then sets additional targets for payers to have their payments specifically for primary care and general acute care hospitals under model 3B and above over time. So that's how they structured their compact, and then they created a work group to figure out how to get there. The second example is Rhode Island. They also created a voluntary compact, also through their version of the PPC. Their compact also has principles, action steps, and some targets. They're a little different. They didn't use the land framework and its broad categories. Instead, their targets include a specific timeline for developing a common hospital global budget model and a timeline for development of an aligned advanced value-based payment model for one high volume medical specialty. I'll note they also have language in there about adoption of value-based payment specific to primary care. That work started a couple of years ago. And so because it's actually well underway, they didn't set action steps, timelines, and targets for primary care the way they did for hospital global budget and the high volume medical specialty model. I'll note that before they established the compact, Rhode Island had some other mechanisms to promote the adoption of value-based payment model. So we talked to, or Alyssa talked about OHIC and its affordability standards. One of the affordability standards relates to value-based payment. So insurers are required to have 50% of their payments made through an alternative payment model. And they have to hit certain annual targets for the percentage of insured residents who are attributed to a provider receiving prospective primary care alternative payment, okay, with a goal of 60% by 2024. So the voluntary compact is in some ways a complement to their regulatory requirement that was created by the Office of the Health Insurance Commissioner as part of its affordability standards. So this is obviously a very different approach than expanding the rate review process. In these states, the initiatives are voluntary collaborations that I would say have been sparked by the state's versions of the PPC. In Oregon, there's a separate Oregon Health Leadership Council, which is really an association of insurers and hospitals that has played a key convening role, whereas in Rhode Island, it was the Office of the Insurance Commissioner that played the convening role. So we've got some familiar questions that we've shared with you when we've discussed other cost growth mitigation strategies. Should Nevada be considering strategies to promote multi-payer value-based payment? What's your thinking on why or why not? And do you need any additional information to consider these options? And again, as in the other cases, we're not asking for a recommendation or a vote. We're going to come back to all of these cost growth mitigation strategies so that you can consider them further, including after we've obtained some additional information for you. Belinda, do you want to recognize people as they raise their hand?
Yes, I apologize. Commissioner Khan, please go ahead.
Thank you. Just a real quick question. In terms of engaging in a multi-payer value-based payment, can you do that just through regulation? Or do you have to get any kind of statutory authority to pursue one of those?
You don't need statutory authority or regulation. So,
So it's just
these
voluntary?
are truly voluntary efforts in both Oregon and in Rhode Island, where all of their key stakeholders, and by that I mean the largest provider organizations and the largest payers, have all said, we think that this is something that's important to do and we want to collaborate on it.
Good. Okay. No, I was just wondering. Thank you.
Mm-hmm.
Thanks.
Now, I want to note, in response to your question, you need to have that level of agreement and collaboration among your leading provider organizations and your leading payers to do this. They had that in those two states. If you don't have it, this type of voluntary model won't work.
Okay. Understood. Thank you.
Mm-hmm.
Commissioner McAllister?
Thanks. Yeah, so I'm not sure if we should consider pursuing this, but I think the additional information I would need to consider these policies are the administrative costs of running these value-based programs, and then what happens to patients who are really ill, because the institutions now encouraged to no longer provide care because of capitation. So that's the type of data I'd want to look at.
Yeah. So I have a couple of thoughts in response. So there are two types of costs. One is there are the costs associated with planning all of this. It's a lot of process work, especially if you're doing something in a collaborative, multi-payer, multi-provider basis. So there's going to be costs upfront for playing the sort of convening and staffing role. Someone's got to play that role. And then after the model is selected, then of course there are implementation operational costs for the payers and providers, assuming that it's something other than what they're doing. And I can't quantify that. And of course, it's going to vary based on the model. I would say, in response to your second question or comment on sort of high risk, high need patients. So these models are not all capitation. Capitation, I think, was one of the or a couple of the examples, but they're not all capitation. But to be fair, any payment model that's not fee for service and that is structured so that it's rewarding reduced rates of spending growth, which clearly fee for service is not. For all of those, there is some measure of risk that you're creating a financial incentive that could limit access to care for patients. And so I would say in general, any payment model has perverse incentives. They just have different perverse incentives. And so I would say fee for service has perverse incentives, and so do these value-based payment models. And so as they are designed, they have to be designed asking the question, what could go wrong here? And what do we do in our design to mitigate that risk? And there are ways of doing so.
Thank you.
Thanks for your questions.
And Commissioner Winkler, please go ahead.
Thank you. And I also want to follow up with, or sorry, support what Commissioner McAllister was asking regarding, chronically ill or the incentives that might come up from adopting a value-based payment model. That is something I've always been concerned with them, and I don't feel like I've ever had a good answer on how that's addressed. But I guess for things of more information I'd like to know is, I guess, to hear from the provider side, like why they are also interested in moving to a value-based payment model or system. I think it kind of makes sense for payers, but I'd like to hear what the justifications are for providers, or why that makes sense to them. And I guess I'd like to know, this seems to be a model that's being adopted a lot. I think states have MCOs and things that work under a value-based payment system. Is that information helpful to us or applicable to it being, multi-payer voluntary system?
Could you elucidate your last question? I lost you on that last one.
So we do use, value-based payment systems are being used. And I think particularly you see them with managed care organizations. So I'm just wondering if information from that is applicable to any consideration of trying to promote the voluntary system. Can we take lessons learned from that?
Yeah, well, and we could look at, we haven't done this, but we could look at experience in Nevada and what's worked and what hasn't. And ask providers and payers about that. So that, that might be worthwhile. In response to a couple of things you said earlier, so having been in the room in some other states where I've heard conversations among providers and payers about this, I would say that that where providers are supportive, they are supportive for a couple of reasons. One is some of these payment models afford providers significant flexibility that fee-for-service payment does not, and they view that as attractive. Some of the models, like a hospital global budget, give some degree of revenue certainty, which fee-for-service does not. But I'll also say in some states, I also have heard a recognition from provider organizations that patient affordability is a real problem in their state. And they recognize that their high prices and their high costs are contributing to that. And they see that through the growing bad debt that they have, the number of patients who they have that are underinsured. So there's sort of an understanding and acceptance that lack of affordability for consumers is a problem for their patients and also for them as businesses when they've got people who essentially can't pay their bills. Oh, and the last thing you asked about, so what about the the high risk expensive patients? And you had never heard a response of what to do. So I'll share with you some of the mitigating strategies that I've seen employed. One is to, in some fashion, risk adjust payments so that the payments for higher risk, higher cost, higher burden of illness patients is higher than it is for those whose health status is good. The other is to utilize measures that will counter an incentive to limit access within the financial model. So you include measures of access or equity and tie dollars to them in the payment model. And the third is to adopt a series of measures and a monitoring system to detect where you might have some bad actor providers who are choosing to take actions that could potentially be injurious to their patient panels, which I won't say are ever going to be commonplace, but if you look across a whole state, you're probably going to find some people who might be motivated by the new financial model to do something that would not be desirable. And so essentially you create a measurement and monitoring system to detect those.
Thank you. Anybody else have any questions?
Yes, Commissioner McAllister.
Thank you. So I also wanted to add on to Commissioner Winkler's question about why providers would like these value-based payments, but specifically for primary care, that if there's an extra payment for well care, then there's actually added incentive for both providers and the insurance companies to get patients in for well care, which is better for the patient, it's better for the doctor's burnout, because right now they're getting things earlier on before they become untreatable problems. I ran a practice in Massachusetts for 10 years. We love the value-based payments for the preventative care because it set up an entire system of getting patients into the doctor more frequently for that well care.
Right. Yep. Thanks for mentioning that.
Anyone else had a question?
Seeing no other hands raised, Chair.
All right, thank you very much. We go to our next item on the agenda. This presentation of primary care spend measurement, examples from other states. Michael Bailiff.
Melinda, do you want to introduce this and why this topic's on the agenda?
Sure. So we had heard from one of the commissioners to discuss this in more detail as, our BDR for the cost growth benchmark does include a measurement and reporting on primary care spend in our state. And it would be really helpful to see what other examples we can learn from that are in other states and just, get some more information on this topic and how we can best implement in Nevada.
Thanks. So why measure and invest in primary care? Primary care, or the provision of it, is associated with improved population health and more equitable outcomes. We know from expanding or emerging research that increased primary care investment expands care teams, improves access to what's low-cost care compared to alternatives. and can support connections to public health and social supports for people with social risk. We also know that increased primary care investment reduces some forms of spending. And in fact, I'll point you all to a report published in April by the Integrated Healthcare Association in California that looked at claims experienced for 14 million commercially insured Californians. And they found, when studying primary care spend at the provider organization level, that there was a positive statistical relationship between the level of primary care spend and total cost of care, quality, and patient experience. So the US as a country spends only a third of what other high-income countries spend in primary care, yet our overall spending is more than twice that. And we have much worse outcomes on so many measures. Further, spending on primary care in the US is way lower than for other services, and it's trending downward as a percentage of total spend. And as probably many of you are aware, fewer and fewer physicians are coming out of training and going into primary care. The story in Nevada is frankly a depressing one. 48th in the country for primary care physicians per capita. 2/3 of the state has a primary care shortage as defined by the federal government. And when we look at quality measures that are correlated with provision of primary care, it also doesn't look very good. Diabetics with an A1C test, children with a medical home, Nevada looks pretty poor. So as you might recall, the cost growth benchmark BDR calls for collecting more detailed data on primary care spending. There are a number of possible steps that states can take to improve primary care. One of them is to ensure adequate investment in primary care. And that starts by measuring what is the level of investment. So let's consider for a minute what other states are doing when it comes to understanding primary care spending and to promoting investment in primary care. So there are a growing number of states that are measuring primary care investment as a subcomponent of total healthcare spending. So they understand what portion is going to primary care and making some determination of the adequacy of that funding. And then using that information to potentially create a primary care investment target or even a requirement and to measure progress. States are sometimes coupling this measurement of primary care with efforts to support primary care care transformation and or to implement payment innovations for primary care. So for example, we are doing some work right now with some of Sarah Bartleman's colleagues at the Oregon Health Authority to develop a multi-payer primary value-based primary care model that's going to be more supportive of primary care practices than the current fee-for-service model. And then states are actually creating either voluntary primary care spend targets or requirements. And so let's look at what 6 states are doing. So there are 6 states that have set primary care investment targets. Sometimes these are aspirational targets, sometimes they are voluntary multi-party agreements, and sometimes they are requirements in state statute or regulation. So these are presented alphabetically. Colorado passed legislation 3 years ago that set targets for investment. In their case, they're looking for an increase in the percentage of total spend that goes to primary care of 1% in each of 2 years. Connecticut set a aspirational primary care spending target first via executive order in 2020, and then earlier this year they passed a bill that codified the spending target in statute. They are aiming towards 10% of total spend going to primary care across all markets, commercial, Medicare, Medicaid by 2025. Delaware passed legislation 4 years ago, creating a primary care collaborative, which led to legislation passing this year, creating a primary care spend target. Theirs is 11.5% by 2025. I would caution you as you look at these percentages that what they define as primary care varies in substantial ways by states. And so you can't make apples to apples comparisons here. The key point is they are setting quantitative targets that are either aspirational or their requirements. Oregon again, back in 2015, they passed legislation to measure and report. In 2017, they passed legislation setting a minimum primary care threshold for all public payers, well, really for their public employee group, for Medicaid, for their plans on their exchange, and for commercially insured regulated plans. And that's 12% by next year. In Rhode Island, OHIC's Affordability Standards includes a primary care spend target. That's been in place for many years, and it's at 10.7% of total medical spending. This is applied just to commercial insurers. So the applicable spending is a variable across these states. And then last, Washington's Healthcare Authority, which is their sort of omnibus health agency, signed a memorandum of understanding with 8 payers to increase primary care investment to a target that's being set as part of something called the Washington Primary Care Transformation Initiative. This is an initiative that's looking at primary care transformation, at recognizing advanced practices, and obviously setting increased investment targets. So there's a lot of activity in this space and more emerging from other states as states are recognizing a need to invest in and support their primary care infrastructure. And that is the last of my slides. So I'm going to stop sharing and open up for discussion.
Go ahead, Melinda. Next one in question in line.
Sure. If anyone has any questions, please feel free to raise your hand. I am seeing no questions at this point, Chair.
So I have an observation on this primary care situation. This has been talked about for decades. Unfortunately, no serious effort has been made to address this, certainly not in Nevada. And that's our challenge. I'm a strong believer in the healthy community and healthy citizens contribute to a healthy economy. And our focus on healthcare system and investing into the delivery of healthcare system has been very, very poor, to say the least. And for example, in Medicaid, we are at one of the lower tiers of expenditure on Medicaid compared to even some of our neighboring states. So that is a challenge. And I think, in my opinion, at some point, our legislative representatives need to focus on this. And the question is always money, to find the resources to address this primary care, not just acute shortage, but access, because the compensation for primary care visits is so low that physicians do not want to see those patients with most insurances. So there is a dual problem, access issue because of shortage, acute shortage, and then the compensation issue. And there are models where they have incentivized delivery of primary care by paying extra for the visit to incentivize these physicians to see these patients with certain insurances. But then there's, if you're going to put quality benchmarks for them, which is appropriate, that you should meet certain quality benchmarks and outcomes for chronic patients of heart failures and diabetes, how you're following through with them, that cost gets added up in terms of overhead. So there is a model in the state by a private company where they have increased their reimbursement to the primary care physicians, and they have added an administrative cost to pay the physician to monitor the quality benchmarks and outcomes and access and prompt visits, et cetera, and in return, they get paid extra. And that has worked very well. So perhaps it's time to look into those things, and perhaps hopefully the legislative representatives will pay attention to this in the next session.
Thank you, Chair. I do want to note, Commissioner McAllister, you have your hand raised.
Yes, so just going forward, I'd like us to consider three things. So what other states are doing to increase residency programs for training more primary care doctors in their state. If there are other states that are doing other tuition reimbursement or other things for medical students who commit to staying in primary care for either a certain number of years or a certain percentage of their practice. Then I also would like us to look at the impact of things like quality of life in the state in attracting primary care physicians to our state, things like the school system and other things like that that attract young physicians when they're deciding where to set up practice early in their careers. I think sometimes we have those conversations in silos, like they're different things, but physicians are motivated by more than just the money, right? They want to raise their families in states that that value children and the whole family, and there are economic opportunities for their spouse, that sort of thing. So not today, we know we're running out of time, but going forward, I think those are the three things I'd like our commission to look at.
Thank you, Commissioner. Any other questions, observations from other commissioners?
Yes, Commissioner Tyler Garner.
Good morning. Thank you. This is a more general discussion for our upcoming agenda. I would just want to know, we've heard a number of approaches today. Beyond the anxiety associated with change, are there any inherent barriers to implementing some of the approaches that we've heard? We don't have to discuss that today, but I would like to know which we are best positioned to implement.
Anybody to answer that? Nobody
I think we'll probably need to do a little thinking about that question and come back to you with some thoughts. Obviously, you all have some perspective on that question as well and should weigh in, but we can at least bring you an initial assessment.
Thank you. Any other questions from commissioners?
Seeing none, Chair.
Okay, seeing none, so that takes care of that agenda item. The next item on the agenda is public comment. Do we have any public comment, north, south, or online?
Yes, Chair. I did want to note we did receive a question from a member of the public during the commission meeting, and I just wanted to read that into the record at this point. So the question is, when reviewing Medicaid or MCO claims and costs, will you be considering the impact of claims and costs and provider types that are 100% FMAP? I don't know what that stands for. I apologize. I ask because the reimbursement rate is set in the Federal Register, and with new designations for tribes, we expect reimbursements to tribes to increase, resulting in higher perceived costs to the state, although it is reimbursed at 100%. And I did want to note, I also spoke with our legal counsel, and the commission is able to answer this question during public comment if it has an answer. Thank you.
Okay, thank you, Melinda. Since we are okay to take any questions or observations or suggestions, then this is the time.
Vice Chair Rubelid, do you have your hand raised? I'm sorry.
Yeah, I was just going to explain what FMAP was if you're interested.
Yes, please.
Yeah, so that's the federal Medicaid match. So basically what they're saying is that these rates and the match is 100% set by the federal government.
Yeah, and I think I can help answer that the question. So when, for purposes of measuring benchmark performance, we look at spending for Medicaid, we will not be accounting for the fact that these services will have a higher federal match rate or FMAP than other services. But I suspect that the services and the associated payments that she's referencing will be a very small percentage of total Medicaid spending. And so I don't think that there will be a substantive impact on the analysis due to the marginally higher federal match for these services.
All right, thanks, Michael. Any other thoughts?
I did want to call for additional public comments. If you are using the Zoom platform, please feel free to use the raise hand feature if you would like to raise public comment, or press *9 if you are joining via phone. And seeing none, Chair.
All right, thank you very much. So I think that brings us to the end of our agenda. I really appreciate everybody's presence and input, and certainly we are ahead of time, which is always good in the interest of everybody's busy life. So I really thank everybody, and we'll meet up at the next meeting, and we'll adjourn the meeting for today. Thank you very much.
Thank you. Thank you,
Thank
Chair Khan.
you.
Thanks.